after we've talked about those two components. Another word for blood pressure is hydrostatic pressure. And it's, as you can see by this white arrow, it's the force applied to the vessel walls. And we have quite a few factors that affect this. Okay? And we can modify those factors by changing body activity, nerve activity, or certainly with drugs. So we're going to look at how much blood gets put into the system by changing cardiac output. We're going to do that a little bit. And then we're going to look at vessel changes, because we can change the composition of the blood, we can change the diameter of the blood vessels, and all of that is going to affect blood pressure. So this is a simple graph of the change in pressure as we move from the aorta, which is where the stroke volume is first entered, and then we turn into the vena cavas. So right off, you can see that as we saw on our cardiac cycle, we start out with a higher pressure than we end up with. And that's required, obviously, for blood flow, because blood's not going to flow up a pressure gradient. Now, notice we have a range of pressure when we're in the aorta and the arteries and the arterioles. That's because we have diastolic and systolic pressure reflected by the force of the heart when it's ejecting blood into these vessels, or into the aorta. So systolic, again, remember, is contraction force, and diastolic pressure is the pressure of the vessels against the wall when the heart is at rest. You'll see this line right here. That refers to mean pressure. That is not average pressure. All right? If it was average pressure, and we said that at systole, our range of pressure, we take a median of that, and we have 120. It's actually a little high and that's going to be systolic. And diastolic pressure is 80. We add those together, we get 200. And if we divide by 2, then we would say our average is 100. And this is given typically not in torrs, but millimeters of mercury as a measurement unit. However, notice that the line for 100 is up here, and the mean arterial pressure is slightly below that. So how do we determine mean? And then we'll move on from there to look at factors that affect. So mean arterial pressure, the heart is at rest usually longer than the time it spends contracting. That's why we can't just put the two together and divide by 2, because there's a time factor involved. It's not 50% of the time at systole and 50% of the time at diastole. All right? So because of that time component involved, it's more at diastole than it is at systole typically. And so we take the diastolic pressure and take the pulse pressure and divide by 3 and then add that to diastolic. So pulse pressure is the difference between the two. Pulse pressure is equal to systolic pressure minus diastolic pressure. Okay. So that would be equal to 40 in our example. 40 doesn't really divide evenly by 3, but it's about 13. Okay. So if we divide that by 3, we get 13 1/3. So if we take our diastolic pressure, 80, plus 13, then our mean arterial pressure is 93, which is just slightly lower than taking the average of the two. Now obviously if your heart is at a higher heart rate, and it's not 70 beats per minute, it's 120, then this formula doesn't work because you're having a greater contractor period and fewer less rest periods, but that's where this formula comes from. Now in lab, if we'd had lab blood pressure yesterday, you would have had an opportunity to take your blood pressure. So I'm canceling that lab, but I would encourage you to do the extra credit PhysioX lab on blood pressure, because that will get you practice with these terms. I'm not requiring it, so it's still an extra credit one. That would be due on Tuesday, so that's, if you're doing that as part of your review, or if you want to do part of it and get part of the credit or something, that's up to you. So factors that are affecting blood pressure. We've already looked at cardiac output, so we're going to review that and look at peripheral resistance. And blood volume is a factor that really affects both. I'm not going to, we'll look at factors when we talk about control of blood pressure. Controlling blood volume is something we're going to look at that will affect cardiac output and peripheral resistance. So what were the two factors that affected cardiac output? Heart rate and stroke volume. Okay? So we saw this graph before. Every slide that I have up here is just a review as far as those two are concerned. So remember, heart rate is affected by autonomic nervous system, and the neurotransmitters, the hormones that are a component here, are acetylcholine and norepinephrine, epinephrine for the hormone. All right. So here's our autorhythmic rate. I should recognize this by now. Pacemaker rate at normal. And the sympathetic effect is to notice the action potential doesn't really change much, but it affects the graded potential. Right? And decreases the time that it takes to reach threshold, whereas parasympathetic is going to increase the time. And I think most of you are comfortable with this concept by now. So parasympathetic, remember, is binding to muscarinic receptors, which means we're using a G protein. Found primarily in the SA and AV nodes, so we really don't affect contractile cells of the ventricle. That change in the cardiac output and stroke volume is going to be left to the sympathetic nervous system. And we had this slide already. So acetylcholine is going to bind to its muscarinic receptor, cause calcium channels to close. So we're not allowing the transient calcium to enter. Remember, that's occurring right here. All right, and in addition to that, it's going to open potassium channels. So we decrease the amount of positive calcium that can come into the cell and increase the amount of positive potassium that's leaving, and so it takes longer to reach threshold. Sympathetic decreases that time. It binds the beta-1 receptors. So SA node and AV node are where we see a change in heart rate. And it also binds to contractile cells, and that's where we see an increase in stroke volume. So it's doing that by opening our funny channels and opening more of the transient calcium. So we're going to decrease the time it takes for positive ions to get into the cell and increase the number of positive ions. Okay, thyroid hormone, we talked about a little bit as well. It increases the need for the body to have oxygen, because more mitochondria are forming ATP, and that occurs in heart muscle cell as well. And so it kind of works indirectly, but it does increase heart rate, which is why people that have hypothyroidism have a higher metabolic rate. Okay? You need to eat more. Interestingly enough, I was just reading, I don't have to get up until 7 on Fridays, and I've been getting up at 5:30, so of course I woke up at 5:30 this morning. So I was checking, Facebook and news and stuff, and there's a 27-year-old woman who just made the U.S. team for track and field. She had a cancer of an adenoid carcinoma, so she had to undergo 38 radiation treatments while she was in college. Got a medical release time so she would still be eligible. Got it back into running, and then she had thyroid cancer, which they thought was unrelated to the adenoid. So she had her thyroid removed, but medication was working for her, so she wasn't thinking about doing racing as a profession, but she's now training and just made the U.S. team there was some controversy, and that's what the article was about, because she was disqualified, and then was reinstated because of a video. Look, another athlete complained that their shoes had come in contact, and that was reviewed and denied twice, and then all of a sudden, they said she was off the team, so I was just reading about that, but she's back on now. So I think without a thyroid gland and on medication, it's still very difficult for many individuals to regulate their metabolic activity. And they tend to be more on the hypothyroid. She was able to function well under exercise. Is there a question? All right. Estrogen decreases heart rate. So it has an inhibitory effect on the voltage-gated calcium, the slow calcium channels. Cortisol increases, surprisingly, even though it decreases our weight loss. And then we talked a whole bunch about hyperkalemia. Remember that? We had a case study on it yesterday. So this is just a summary of the changes, be able to recognize an ECG of what's occurring here. I'll put this up because this is a new slide, so I was working on these slides this morning. I'll put this up on D2L. But essentially, as positive ions enter the pacemaker cells, remember we said they end up blocking sodium control as well as in the contractile cells. We end up, this is the dotted line, is the effect of hyperkalemia. So you end up with a decreased force. And at the pacemaker cells, we end up, it suppresses the hyperpolarization. So we don't reach that eventually because the cells don't get negative enough to open up the pacemaker channels. And so it decreases both heart rate and force. So just a little bit of review here. As we get increased calcium, what we start to see, potassium. All right, then stroke volume. We had several factors that affected stroke volume, if we recall. What was Frank Starling law?
As stroke volume goes up, heart rate goes down.
Okay, so, well, no, not quite. Frank Starling law was, that's cardiac output's just the mathematical component of it. Frank Starling law was this image here. So as we increase the volume, remember the rubber band? As we increase the volume and stretch the actin and myosin, there's a greater force of return. The more the volume is stretched within limits, you can overstretch so that actin and myosin no longer overlap. So that's a factor. And then I didn't mention it in lecture, so I'm not going to hold you to it, but that stretching also makes troponin more sensitive to calcium. So it's going to bind to calcium at lower levels, and so you're going to see a greater effect of having calcium in the cell. So greater stretch, greater return in the force of the contraction. We get a greater stretch when we have preload, all right? That was our venous return, and the effect of the sympathetic nervous system. Remember, I just got through saying for our heart rate, sympathetic nervous system also has beta-1 receptors on our contractile cells, and it opens calcium channels. Now, one of the unique things about cardiac muscle over skeletal muscle, they both store calcium in the sarcoplasmic reticulum. Sarcoplasmic reticulum and skeletal muscle is opened by a current, voltage-gated action potentials traveling down the transverse tubules. What's different, that happens with cardiac muscle too, what's different is that we have calcium channels in our plasma membrane. And when these open, again, because of protein kinases, that causes even more sarcoplasmic reticular calcium to be released. So extracellular calcium becomes a factor in cardiac muscle cell, although it's not a factor in skeletal muscle cell. All right, so we had cardiac output and stroke volume. So now let's look at peripheral resistance. There are 3 things that affect peripheral resistance. Your lecture notes talk about how to do blood pressure, and we covered that already. So there are 3 factors that affect peripheral resistance. And resistance is resistance. All right, so if I have my controls for the overhead and I try to slide it, we've got a little bit of rubber on the back, it just doesn't slide very much. I turn it over to the front, so it's meeting resistance. All right, if I put an oil or something on that surface, that would decrease the resistance and it would move more easily. So peripheral resistance is going to increase hydrostatic force. One of the factors is vessel diameter. Another factor is blood viscosity. And then total blood length is the third factor. So blood vessel diameter is going to be dependent on the diameter of our peripheral blood vessels. All right? So remember which one was the most important blood vessel?
Arterial?
Arterials. All right? Because arterials, let me go forward here a little bit. Arterials don't have quite as much surface area as capillaries do. So why wouldn't capillaries be the site where we have the greatest control? We have more of them. We have the greatest number of capillaries than anything else.
Because they're leaky?
No, yes. We can't control them. We can't change the diameter, so we can't constrict them and we can't dilate them because they don't have smooth muscle. So, I mean, we obviously can constrict and dilate arteries in the aorta, but there's only one of them. So if we take the aorta and we go to this, we're not changing, there's not as much total surface area, same volume, but not as much total surface area than if we had 100 vessels, each carrying the tenth of the volume of the aorta, but there would be more surface area for that total volume. Does that make sense? Because each vessel, so then that adds not only to the surface area and resistance, but it adds to the ability to change the volume. And so arterioles are the smallest vessel that still have blood vessels that we can use to affect blood pressure. Okay? So these are, we'll look at these as hormones towards the end that affect constriction. So primarily norepinephrine is our sympathetic component. So when you have, yesterday was a really nice day in the afternoon. I didn't wear my jacket when I went home. We stopped off at the grocery store, and the grocery store was freezing. By the time I came out of the grocery store, the distal ends, the last couple inches of each finger was yellow, and my fingernails were gray, and my fingers were numb. That's peripheral vasoconstriction. It's also called Raynaud's syndrome if you have it really bad. It doesn't happen all the time, usually in my little finger, but this was both hands, primarily this hand, and that's an effect of cold response due to the sympathetic nervous system. The sympathetic nervous system is the only part of the autonomic nervous system that affects peripheral vessels, except, remember, parasympathetic in the penis when we talked about erection, or clitoris for that matter. For the rest of the body, norepinephrine is responsible for both vasodilation and vasoconstriction, up or down. Angiotensin II and vasopressin will also result in vasoconstriction. They are involved in blood pressure control, and they involve control from the kidneys. In fact, ADH has a control in the kidneys for reabsorption of water, but it also functions to cause smooth muscles to constrict. So it's called vasopressin, and that's why I use that term first rather than ADH, because we're looking at vasoconstrictors. So these will all increase, in each of these chemicals is going to increase blood pressure because it's constricting the blood vessels and increasing peripheral resistance. Blood viscosity. How many of you have heard of the term hematocrit? It's a term that we will cover with our blood cells because it's one of the blood tests. It's done by taking blood in a small tube and spinning it down. And it's a ratio of the volume of blood, which is mostly blood cells, which are mostly red blood cells, to the total volume of the blood. So you'll get numbers like, what average is about 42 to 45% for women, about 45 to 50, 58, 48 to 52 for men. So over here you can see the hematocrit is higher. There's a higher proportion of the blood that is blood cells. So it's kind of like making black bean soup, all right? If I take a cup of beans and 4 cups of broth versus a cup of beans and a half a cup of broth, you can see that one's going to flow more easily. So with a greater number of blood cells in the blood, there are more of these cells are going to be bumping against each other and bumping against the surface of the blood vessel wall, increasing blood pressure. So we, as we'll talk about when we get to the blood cells, we can change hematocrit by changing, or viscosity, by changing blood volume, drinking more water, or making more blood cells, or doing the reverse. So either the cellular or the fluid content can be changed to affect blood viscosity. All right, then the third one was the length of the blood vessels. So this is showing vessel diameter, how that changes. So it decreases as we get to capillaries, increases as we get to veins. Total cross-sectional area is greatest in the capillaries. And the more we have of all of these vessels, the more surface area there is. That's a little difficult to change. You can't just wake up one morning and take your blood pressure and say it's too high. Well, I've got to decrease the number of blood vessels I have. And do that by nightfall. Unless you have an amputation or something, okay? Obviously, the more tissue you have, the more blood vessel length there is. So losing weight, there's more blood vessels for adipose tissue than there are for muscle tissue. But again, that's kind of proportional. Like I said, my mom is about 100 pounds overweight and has lower blood pressure than my dad, who's on medication and isn't overweight at all. So there could be other factors that affect blood pressure. And he probably has more constriction than she does. Her vessels are more dilated, so the greater number is not as effective. Okay. You have this chart in your lecture notes, but you don't have the arrows. So you're on page 112. So it's kind of a summary of what's going on. And then I want to look at some specific hormones that affect blood volume. So all of these arrows just go down below. And then this one has 2 arrows. So increasing sympathetic stimulation, increased epinephrine is going to increase heart rate and increase stroke volume, or heart contractility. And then increased contractility is going to lead over here to increased stroke volume. So this is just a one series of arrows all in one direction. Here, this goes to 2 locations, and then this comes over to affect stroke volume. So down here at the bottom, increased heart rate is going to increase cardiac output. Increased stroke volume, its arrow goes this direction because that also increases cardiac output. And then we have the 2 major factors I had on the previous slide. Increased cardiac output and increased resistance are going to increase mean arterial pressure. So at the arterial itself, and I'm not just going to do a summary here. I don't ask specific questions about this on the exam. This is more blood flow rather than blood pressure. Okay? If we decrease blood flow at one specific area, blood pressure is going to back up behind it. So it is linked to blood pressure. But we're looking at specific areas. Remember we talked about these little sphincters that can redirect blood flow? So this is at a local area that we're talking about. So if there's increased oxygen in a tissue other than an increased need for oxygen, shown by a buildup of carbon dioxide as the cells are using up the oxygen and creating carbon dioxide, or a buildup of lactic acid, or a release of the relaxation factor from these blood vessels themselves, okay, that will cause, each of these themselves are vasodilators. So there's a local control at the tissue that can change the diameter of these vessels right here. Not upstream, but right at the entrance to those capillaries. So it can affect, if that happens throughout the body, that will affect blood pressure, right? When we get to the urinary system, we'll talk about how it works right at the kidney, because of course the kidneys are very involved in regulating blood pressure right at the kidneys, because that affects their function. But then we have a systemic control of blood pressure and blood volume. So I wanted to just let you just kind of basically say, all right, we have factors that at a stomach wall or your gastric media that are interested in increasing oxygen just to those tissues. So we're going to see these chemicals that can dilate the area just to those tissues. And then we have chemicals that work across the systemic area. I'm just going to go over a brief effect because almost all of these are involved with kidney function. So I'm not going to go through the long, complicated pathways of activation, just basically what happens when these chemicals are released into the body, all right, for the systemic effect. And this slide here is on the PowerPoints already up. So let's look at some hormones. I think there's about three or four. Antidiuretic hormone is the same, let's see, we first have baroreceptors. Okay, well let's look at that first. I don't have a slide for that, but we'll just talk about it. So, what does the word baro refer to? Barometric?
Pressure.
Pressure. Barometric is regulating it. So we're on page 118. Sorry. I've gotten rid of that picture actually. We have pressure receptors in two areas of the arterial system. They're in the same place as we have chemical receptors for the amount of oxygen and carbon dioxide in the blood. Both of these are in the arterial vessels. So in the arch of the aorta and in the branch where common carotid divides into internal and external, we have baroreceptors. Sensory is vagus and glossopharyngeal nerve, which often overlap functions anyway. So as pressure drops, what is the response of the autonomic nervous system going to be? There's a detection and a decrease in the diameter of the aorta or the carotid vessels. Increase in sympathetic. All right, that's the response of the autonomic nervous system. If pressure is high, then the response is going to be to decrease sympathetic and increase parasympathetic. All right, it seems complicated for some of these issues, but there's so much underlying commonality that you can start to figure things out. All right. So in the baroreceptors, that's why we see a factor for that. With the chemicals that are involved, this is the same vasopressin that I had mentioned earlier. Antidiuretic hormone is released by posterior pituitary. It's going to affect both vasoconstriction, but at the kidneys, that's systemic. It's going to cause blood vessels to constrict. So it's going to increase peripheral resistance by causing blood vessels to constrict. It also affects cardiac volume, cardiac output, by increasing blood volume. It does that by causing the body to reabsorb more water. So if you have an increase in ADH, your urine output is going to go down, and your blood volume is going to go up. Your blood volume goes up, what happens to venous return? It goes up. If venous return goes up, end-diastolic volume goes up. End-diastolic volume goes up, Frank Starling's law says, there's an increase in contractility, and stroke volume goes up. If stroke volume goes up, cardiac output goes up, cardiac output goes up, blood pressure goes up. Okay? So it's just a if then, if then, if then, all the way down, following the same, bless you, following the same sequences that we've gone over already. But it does so through these two mechanisms. So if someone is in congestive heart failure, would you want them to have high levels of ADH or low levels of ADH? Low, because we're giving them diuretics. We want to decrease their blood volume so there's less in diastolic volume and less work for the heart. Okay. Aldosterone. Aldosterone is a hormone released by the adrenal gland. It also increases water reabsorption from the kidneys via a different mechanism, which we're not going to get into now. What is one of those Marian or Little Lamb? Sodium is removed from the filtrate and returned to the blood, and water follows passively. So the same sequence of events as we just saw with ADH. ADH is also removed by the blood because of sodium, but no, we won't worry about that. We'll get into that with the urinary system. The sodium is removed first, and later on, the ADH will work. Aldosterone works on removing the sodium, and it's a passive removement of the water. But both of them are going to end up with an increase in blood pressure, because we have an increase in blood volume. This is the only one that decreases blood pressure. It also works on sodium. We talked about this a couple days ago. So remember, our atria are stretched. Well, what's going to